Okay. So despite obvious linguistic difficulties and cultural difficulties, I've been told by one of the attendants in the break I need to smile more. So here we go. All right. So welcome today. Thanks for coming out. It's a beautiful day. It's great to have our weather back. So hopefully we'll get through this and go to the beach and do something enjoyable. Okay. So I'm talking about management of difficult rotator cuff tears. Now, I guess the principle of this talk is both to identify when you should be worried about tears and thinking that these tears aren't getting better with non-operative treatment and need surgical treatment, and give some idea about the natural history and what our treatment options are with these very difficult tears. What we don't want to have happening at the time of surgery, if we can avoid it, is have this sort of appearance where you have a large, chronically retracted rotator cuff tear with fixed retraction and significant muscle atrophy, and that can be a very difficult situation to treat. So we should go on and talk first, I guess, about the natural history of rotator cuff tears. Now, the natural history of rotator cuff tears is not all that positive. There's been many studies that have elucidated the natural history, both the MRI, re-scoping, ultrasound scans, and the natural history of rotator cuff tears is one of progression. So partial thickness tears tend to become full thickness tears, small full thickness tears tend to become large full thickness tears, and about 75% of people with a large rotator cuff tear will go on to develop a rotator cuff arthropathy at some stage of their life. So the importance of that is really dependent on the age of the patient and their functional ability and their response to non-operative management. The other thing that happens with a rotator cuff tear is over time that the tendons become degenerate. They go through a process of metaplasia where they stop being tendinous-like tissue and become more cartilage-like tissue, which is less likely to heal. The tendon itself can atrophy and get smaller and get reabsorbed. And also the amount of inflammatory cells at the tear margins gets less, so they have a lower inflammatory capacity to heal. The other thing that happens with tears is fatty atrophy, and I'll talk more about this in the next slide, so I'll just leave this at the second. Then what happens is the tear size gets larger, and we're not talking about the little U-shaped tears. These are the big tears, whole tendons, multiple tendons. They retract back, and the retraction itself is not a big problem, particularly in the acute scenario. But over time, and it can occur relatively quickly, the tendon tears that become fixed, they develop fixed retraction. And that is a very difficult problem to fix surgically. And eventually, the end stage of rotator cuff tears is a rotator cuff arthropathy. Now, what happens with the rotator cuff arthropathy? As you guys know, it's a special sort of arthritis related to a large rotator cuff tear. And the pathology is that the deltoid overpowers what's left of the rotator cuff, the proximal migration in the humeral head. That leads to increased shear forces on the articular surface of the joint, point loading, and wear against the chromium. These lead to mechanical degeneration of articular cartilage. Combined with this is that the erosion of the chromium releases hydroxyapatite crystals in the joint and a very significant inflammatory response resulting in enzymatic degradation of the articular cartilage, leaving with a potentially quite a dysfunctional shoulder. Going on to fatty atrophy, what fatty atrophy is, the rotator cuff does something that's relatively unique, is if with a large tendon tear, the muscle loses its attachment to the bone and is unable to generate load. As a response to this, the muscle fibres go through fibrofatty degeneration, and this is irreversible. They get replaced by fatty fibrous tissue and it just doesn't come back. And so we want to avoid this, because if you've got severe fatty atrophy, the rotator cuff is useless, whether you can repair it or not. There is a classification for it. The first one was the Gotelier classification. Now, The important thing about this classification, or one of the important things, is it's often overcalled by the radiologists. Because what you need to make this classification is you actually need to see the acromial spine, because it's the fill of the supraspinatus within the supraspinatus fossa. If you get, for example, this view here, you can overestimate the degree of fatty atrophy. And the reason of that is if you look here, that supraspinatus is actually a cone shape. So if it's torn here and it retracts back, you make a cut through here, there's going to be more fat than there actually is. So if you grab that tendon and bring it back, the muscle belly comes back and fills out that fossa. But that's a mechanical change. This is a biochemical change. So there's four grades. One is streaking. 2 is decreased muscle within the fossa, but there's more muscle than fat. 3 is muscle equal to fat, and 4 is fat is greater than muscle. By the time you get to grade 4, your rotator cuff is pretty much totally gone, okay? So we want to avoid that, and that can happen relatively quickly. And some patients start getting signs of fatty atrophy within weeks, but generally it more commonly develops over 4 to 6 months, certainly over a year, although some people are more prone to it than others. So factors affecting cuff repairability. The major factor is time to surgery. The longer you leave a rotator cuff unrepaired, the less likely it is to be repairable because of the before mentioned factors, fatty atrophy and fixed retraction being the major ones. So if you've got a patient with a large rotator cuff tear that you're treating non-operatively, and they're not making significant progress in, say, 6 to 8 weeks, it's time to think again that maybe this mightn't be the right option for them. Smaller tears, not such a big deal, but large tears, large retracted tears, it's a big thing. So there's the size of the tear. Now, the size of the tear is in itself doesn't indicate how repairable a tendon is. It's more that the time it's been torn because of fixed retraction. If retraction's not fixed, then you can repair any size of tear very easily, and it's got a very good chance of healing. But if you leave it too long, you get fixed retraction, it becomes a big issue. We've talked about tendon quality and fatty atrophy. The other thing that should note is adhesive capsulitis. If you've got a patient with a large rotator cuff tear that you're treating non-operatively and they start developing signs consistent with adhesive capsulitis, that is a big problem and it needs to be dealt with relatively urgently, because if those patients get adhesive capsulitis, their cuff gets dragged back with the retracted capsule and it becomes irreparable very quickly. Okay, so those patients, if they're sort of borderline, they start getting symptoms of a frozen shoulder, you need to send them back to the surgeon to get treated. The other scenario that you should be aware of, if you have a patient with a significant injury who presents to you with symptoms and signs consistent of adhesive capsulitis, but that have significant trauma, those patients should have an MRI scan, because what may happen is they may have torn their rotator cuff, developed a capsulitis, and you can't diagnose their cuff tear because of the frozen shoulder. So those patients, in my opinion, require an MRI scan just to check their cuff. Because they're not going to thank you if after 18 months the frozen shoulder's worn off and they've got an irreparable cuff tear or even a significant cuff tear. Okay, so factors affecting healing. Well, age is one thing that people always talk about, and it's controversial. Some studies have shown age, or advancing age, to be a negative factor in rotator cuff healing. Some studies have shown that older people do better than younger people. And a big study by Weber was published in the Journal of Orthopedics looking at insurance company data. They looked at over 22,000 cases and found that age had no effect in rotator cuff healing. So older patients do very well with rotator cuff repairs. The major thing is, again, time to surgery due to the factors we already talked about. We've covered biological healing potential in tendons. Smoking's a big issue. The issue with smoking is that nicotine's a very powerful vasoconstrictor. That's why it destroys your cerebro, cardiovascular and peripheral vascular system. The blood supply to the rotator cuff's not very good. If you're a smoker, it's probably worse than normal. If you're keeping smoking, the vasoconstriction of the nicotine while you're smoking deprives the healing rotator cuff of a blood supply, increases the failure rate significantly. So if you can give I find it a good public health opportunity to jump in there and try to give people a good reason to stop smoking. Because you see them, some patients that shouldn't fail, they do because they're smokers. Corticosteroid injections is an interesting one. In that same study by Webb, again looking at over 22,000 patients, they found that rotator cuff repairs performed within 4 to 8 weeks of a corticosteroid injection had a significant increase in failure rate. So they returned to relatively baseline after 8 weeks. But the other interesting factor is if they'd had 2 corticosteroid injections, the increase in failure rate was still persistent at 12 months. So that's made me rethink my practice a little bit when trying to get treating people non-operatively. And again, it sort of skews to being slightly more aggressive if they're not getting better. There is a potential confounding factor, though, is that the time to surgery is being increased. So that is a factor. And, time to surgery, Fu published a paper in the Journal of Arthroscopy looking at rotator cuff repairs, and these are small repairable tears. They're not the big retracted tears, they're small ones. If they were repaired within 12 months, the failure rate was about 9%. If they were repaired after 12 months, the failure rate was about 15% due to the decrease in biological healing potential. General health's a significant thing. Renal failure obviously has a negative effect. Diabetes, and interesting, uncontrolled hyperlipidemia has a detrimental effect to rotator cuff healing. And then you go into surgical techniques. And the general principles of surgical technique is anatomical repair with reducing tension at the repair site. So looking at a really crucial thing when you're looking at surgical repair is to identify the tear pattern and identify it anatomically, just like you do for a fracture. Because failure to do so will lead to failure to restore the appropriate tension in the muscle tendon units, and also can lead to increased tension at the repair site and increased failure. Now, there's many different patterns of rotator cuff tears, not just all the crescentic U shapes, there's L shapes, reverse Ls, delaminations. And they must be identified and put back where they belong, because it can affect your failure rate quite significantly. If you're looking at a tear like this, you might think, well, that's just a U-shaped tear, you can just spring back to there, it's going to be sweet. In fact, that's a reverse L-shaped tear. So that tear has torn and it's gone that way. So it needs to be advanced more in an posterior to anterior way to get it back. And tears that often look irreparable in first appearance, when you actually assess and work out their tear pattern, are easily repairable. Okay. And that's an MRI scan looking at different tear patterns. That's a bursal surface tear with delamination, intrasubstance tear. And the delaminated segment's also very important. Delamination is actually very common in rotator cuff tears. And you need to repair the delaminated segment to perform the tear repair adequately. Going onto the old chestnut, single versus double row. This is one of the things that surgeons like arguing a lot about, like cemented knees and hips and non-cemented knees and hips. They're effectively equivalent. They both have some advantages, some disadvantages, and it really depends on surgeon's preference, tear patterns. The advantages of a single row is you don't need to advance the rotator cuff so much to reconstruct the footprint. I think it's actually easy to reconstruct complex delaminated tears using a single row, as you've got more flexibility with your suture placement. It maintains the blood supply in the distal cuff, but you do need to be able to tie knots, which is something that people are getting less au fait with, unfortunately. The advantage of the double row. Advantage of the double row, it's got slightly increased in mechanical strength and lab testing. Although if you use modified Mason Allen suture in your single row, it comes to essentially equivalent. The disadvantage is you need to mobilise it further to restore the footprint. Also, this pattern of sutures over the footprint can decrease the blood supply in the cuff and decrease its healing potential. The other issue with it is when it fails, generally it fails through those medial suture holes. And that leaves you with a the majority of the tendon attached to the great tuberosity, not very much tendon attached at all to the rotator cuff, which is a very difficult problem to salvage. The other thing you need to be able to deal with is long-headed biceps. If you have an unstable long-headed biceps in the shoulder and you leave it in situ, it's going to cut through your repair and fail it, and it'll fail, so that needs to be dealt with. Surgical techniques, this is for fixed retracted tears. There's several techniques to deal with those. One is the double interval slide. It's basically developing the interval between the subscapularis and the supraspinatus. In fact, what you're doing is dividing the coracohumeral ligament and also developing this interval here. You cut through that tendon, hopefully avoiding the suprascapular nerve, which is running around here. And that often gives you enough excursion to be able to repair those tendons, even with fixed retraction. There's muscle advancements techniques where you make cuts on the medial border of the scapula, elevate the supraspinatus and infraspinatus off the respective fossas, and that allows you to translocate the tendons more distally to achieve a repair. Often obviously has effect on the length-tension relationship of the muscle, but it has been shown to be relatively effective. The other thing is marginal convergence. If you decide these techniques are not going to work, and the leaflets are repairable side to side, you can not worry about the supraspinatus so much. Repair the leaflets, and it allows the rotator you've got to exert a depressor effect to balance the deltoid. And those all work, but they do have their issues, and some of them are technically difficult. Risk factors for repair failure, obviously all the above, and compliance is really a major issue. You know, failure rates, success rate's pretty good, but a big elephant in the room is patient compliance. And if they do the wrong thing, your failure rate's going to be 100%. So they need to be educated, and you need to keep them on board with what their limitations are. Unfortunately, therapist compliance, surprisingly enough, can be a bit of an issue as well. The problem with rotator cuff tears and their healing is it takes forever. And people go, oh, I'm just doing that same bloody TheraBand exercises day after day. And the tendency is want to push on and get excited and, you know, all sorts of things. But look, it takes 6 months for the bone tendon interface to heal. And if you do too much and it falls apart, the patient's back to square one and they're not going to be happy. Often they're not happy anyway. So looking at failure rates of rotator cuff tears, generally it's a very successful operation. Looking at the literature, failure rates vary from about 5% degraded to 50%, depending on the above, and also depending on mostly retraction, fatty atrophy. And massive fixed retracted cuff tears requiring interval slide and revision rotator cuff repairs, the failure rates can be up to in excess of 50%. So that's huge. So, I mean, often the fixed tears, even though you're doing your releases, are being repaired under some traction. They're often old, so they get the reduced biological healing capacity of the tendon. And in revisions, you know, these tears there's something going on, and a lot of these patients might be compliance, but might have something else to do with the biological healing capacity of the tendon. And here you can see an MRI scan. This is of a failed double row repair. You can see the tendon healed very nicely to the footprint and looks fantastic. Unfortunately, there's the muscle there with no tendon attached. That's a very difficult thing to salvage. We don't generally want to see this sort of thing. Retracted, fatty atrophy, you know, the works. So what I've been doing for the last few years, in fact, a lot of people have been doing, is supplementing with dermal human allograft as a patch or as a superior reconstruction to reinforce the repair or treat non-repairable rotator cuffs. And the success rate using these techniques have increased significantly. So the graft patch we use, it's a piece of dermal skin from a dead person. A dead person in the operating theatre can whip out and take some off and put it in. No, actually, they're acellular. It's acellular that's been treated. There's no human DNA left. And these are quite strong. They've got the consistency of sort of soft leather. So they've got a very good structural component. And when I'm doing revision surgery or surgery when the tendon quality is poor, or maybe in a high demand person like a contact athlete. In a repairable tendon, you mobilise, you do your releases, you repair the tendon, and then you put the patch over the top. Both act as an internal brace and as a collagen graft, because this will integrate with the tendon, give you good tendon thickness to hopefully prevent it failing again. It's fixed medially to the tendon. In this diagram, those are staples. I don't think they're strong enough. I actually suture it to it, and I repair it with a separate row of anchors laterally on the great tuberosity. And I found this to be very effective. Often people find it a lot more comfortable, probably due to the splinting effect of the graft. Going on to superior capsular reconstruction, you utilise this in patients who've got non-repairable rotator cuff tears who are too young to have reverse total shoulder replacements. And I was initially very sceptical, but I started using it just because you've got that patient group you haven't got a lot of other options for, and actually been very pleased with its results. It is very effective. And what you do is basically you require an intact or repairable subscapularis for it to work. You repair your subscap if you need to. You repair what you can of the rotator cuffs, at least normally can get some of them for spinatus back up. And you basically put this patch between them to bridge the deficit. It's fixed on the glenoid using 3 anchors, and then onto the tuberosity using whatever technique you prefer. And then you sew the rest of the rotator cuff to it. And that both acts as a passive restraint to proximal migration of the humeral head, maintaining the subacromial distance, and also allows the rotator cuff you've got to express some depressor effect and restore the force couple that's missing. And it actually works very well. Other things that's coming up for improving outcomes, biologics are very sexy and trendy. There's all sorts of things being tried. There's the platelet-derived growth factor. We used to have something called Augment, which would soak those little grafts in. Unfortunately, this company sold to another company. They're no longer available. I haven't noticed any difference, so I'm not sure that's just very expensive normal saline or what. Platelet-enriched plasma, it's a bit of a treatment looking for disease. It's used in everything at the moment. Fibrin clots, bone marrow aspirate, and tenocyte transplantations, there's lots of things. The Genitin patch, this is on the market now. It's made from bovine collagen. It's bioinductive, but it hasn't got any structural integrity. So it's probably good for utilising for supplementing partial thickness tears, but I don't think it's got enough integrity to be used in revision surgery personally, although I could be wrong. The BioRes, this is a new implant coming out in the market. It's being used in the human population in the US at the moment, with no human trials, believe it or not. What it is it's a mesh of PLA, which is bioabsorbable plastic, combined with the mesh of bovine-derived collagen. And there have been some studies here done at UNSW at the Biomedical Engineering Lab in animal models, and it does seem to be very effective. In fact, it seems in the animal model, which you've got to take with a grain of salt because animals, we are animals, I know, but we're not the same animals, is that it seems to reduce the healing time by about 50% in that model. So we're actually starting to embark on the world's first human trial here in Sydney. So watch this space, see how we go. Also, in certain patients, young patients who've got grade 4 fatty atrophy, irreparable rotator cuff tears, tendon transfer is an option because the only other option is really reverse total shoulder replacement. These are the standard tendon transfers. The issues with a lot of them is the pull of the tendon transfer doesn't equate with the pull of the muscle being replaced. And also, so often these tend to work more as a tenodesis effect. So if you're preparing the posterior superior cuff, that might stop you falling to internal rotation, but giving you more function in the sagittal plane, although there's some studies have shown some actual muscle activity. Get out of jail card for irreparable rotator cuff tears is a reverse total shoulder replacement. Ideally in older patients, but sometimes you're forced to do it in younger patients. And it's a good operation, gets people out of pain, improves their function, but there are some issues with it, and not everyone does as well as you'd like them to. Okay, thank you very much.